And typically, vomiting in pregnancy starts around 4 to 5 weeks, maybe even up to about 6-7 weeks. And it gets worse towards about the 9th week. But by about 18-20 weeks, over 90% of the people would have improved, and they will not continue to have vomiting. Although people have vomiting is fairly common, most would be able to tolerate food and liquids. But this problem of not being able to tolerate and having severe vomiting is seen only about small percentage of people, maybe up to about maximum about 3%. Now, when you have patients who come with vomiting, we have to make some assessment as to the degree of vomiting. So this is one of the questionnaires that were designed to assess the degree of vomiting, which is called a PUQE scoring system. It's a quantification of vomiting. Okay. Now this is useful because this kind of thing is useful rather than patients saying I had 4 times or 5 times vomiting. This kind of scoring system gives fairly sort of objective assessment of the degree of vomiting. So that is useful in that sense. Now I said, when it's severe, when the patient has severe nausea and vomiting, when you have severe nausea and vomiting, when you have severe nausea and vomiting, you tend to get dehydration, you tend to get electrolyte imbalance, and you tend to get weight loss. Now, for you to diagnose severe nausea and vomiting in pregnancy, which we term hyperemesis gravidarum, we have to have this triad of losing at least 5% of their weight, 5% weight loss, dehydration and electrolyte imbalance as a result of having severe vomiting. Okay, so when you take this group is fairly small percentage, going up to about maybe in certain areas might be 0.5%, maybe maximum of about 3%. Okay, so you diagnose hyperemesis on grounds of 5% weight loss, dehydration, and electrolyte imbalance, and it's not a very common thing. It's there, maximum going up to about 3%, but importantly, it can have very serious consequences. As I told you, it typically starts between 4 to 7 weeks and peaks around 9 weeks and resolves by about 20 weeks. There are certain people who are at risk, or in certain group of people where this hyperemesis or severe vomiting is more prevalent and more frequent. So if you have previous pregnancies with hyperemesis, your previous experience, or people who are obese, of course with people with multiple gestation, and people with what we call trophoblastic disease, we'll talk about trophoblastic disease later. That is where you have again sperm sort of fertilizing, but the fetus won't go and the placental tissue proliferates, and it's called trophoblastic disease. Then in first pregnancies, it's common, nulliparity, young people, and strangely, it is more commonly seen when you carry a female fetus. Okay. Although I don't encourage people to take alcohol and smoking during pregnancy, it has been shown that those two reduces the hyperemesis. And why it happens, why you get some people get severe nausea and vomiting, it's not really known. There's no exact etiology form. But there are various theories to show that certain factors are likely to contribute to development of hyperemesis gravidarum. One thing is what we see is the now when you are pregnant, as you know, you have a rising HCG concentrations in pregnancy. Now, if you look at the pattern of rise of human coronary gonadotropins in pregnancy, you find that is also rise starts around 4 weeks, peaks around 9 to 10 weeks, and also that levels drops around 18 to 20 weeks. So this pattern of vomiting also goes along with it, and similar pattern starting around 4 to 7 weeks, peaks around 9 weeks, and settles around 18-20 weeks. That is the pattern of HCG rise as well. So because of that, and also the fact that this is more common in situations where there is a high HCG levels, like in twin pregnancy, like in trophoblastic disease, it is thought that the high level of HCGs is etiologically related to the development of hyperemesis gravidarum. So that's one possible factor. And there are certain other possible factors that are operational. And there is also thought to be some familial tendency for you to have this vomiting. So there may be a genetic element. Because it's found that daughters of mothers who had severe vomiting in pregnancy, or if your sister had severe vomiting in pregnancy, you are also more likely to have it. So there's a familial tendency which may be genetically related. Then there are certain other conditions like having possible theories of any condition which leads to abnormal gastric motility, and also certain other conditions where another sort of possible etiological factor that has been shown is the infection with Helicobacter pylori, the bacteria. Okay, because what we found is people who have hyperemesis gravidarum tend to have high concentration of Helicobacter pylori in their gut. Okay, so basically Helicobacter is a bacteria which is found in the stomach, which can aggravate nausea and vomiting in pregnancy. Okay, so that's again possible factor that may be operational. Then question is whether there's a psychological element to these people who are having severe nausea and vomiting. Of course, there is nothing to say people who have severe vomiting in pregnancy are sort of people with psychiatric disorders. But there are certain situations like if you get pregnant, when you have an unwanted pregnancy, okay, and whether that kind of reaction is a way of rejecting the pregnancy is something that has been thought about. But there's no direct link with psychological disturbances to this severe vomiting. So we don't know. Okay. What is also found is that nausea and vomiting during pregnancy is related to high estrogen levels and high progesterone levels, which occurs during pregnancy. As you know, if you have high progesterone levels, it will inhibit the smooth muscle function and the contractility and the motility, so that you tend to have GI disturbances which might be predisposed to vomit. So it is also thought that certain thyroid dysfunctions and immune system issues also could be contributed. Now, all those are possible sort of related factors, and we cannot pinpoint exact etiology for this thing because sometimes it's multifactorial. Okay. Now, for you to diagnose, when you say diagnose, we said, of course, if you have severe nausea and vomiting in pregnancy, which results in 5% weight loss, dehydration and electrolyte imbalance, that fits into the definition of hyperemesis gravidarum. But you have to be aware, all patients who have this severe vomiting in pregnancy may not necessarily be having vomiting because of hyperemesis. So there can be so many other causes of vomiting that can occur whether they are pregnant or even otherwise, even with non-pregnant ones. So when you have a patient who presents to you with severe vomiting, it's very important that you exclude the possibility of other conditions which are maybe related to gastrointestinal tract, may be related to urinary tract, certain metabolic disorders, neurological issues has to be considered, right? So once you look at those and you rule out the possibility of a pathological cause for nausea and vomiting, then only you can perhaps confidently say that this is hyperemesis gravidarum, and this is where pregnancy-related vomiting occurs. Now, when anybody has severe nausea and vomiting in pregnancy, whether you are pregnant or otherwise, it can lead to several changes, right? With your severe nausea and vomiting, obviously you are going to get dehydrated. Okay? Then it will lead to acid-base balance derangement and electrolyte imbalance. We end up in hypokalemia, hypochloremia, and kind of thing. Okay. It will lead to hemoconcentration because of the dehydration. It will lead to hemoconcentration and it will lead to elevated PCV. Then, as a result of severe dehydration, you can end up having high blood urea and high specific gravity in the urine. It is also found that patients who have hyperemesis gravidarum tend to have abnormal liver enzymes, although they are not very high like in a patient with sort of hepatitis, but liver enzymes goes up to about maybe hundreds, 200s, but not very high to 800, 900, and 1000 when you have a severe hepatic damage. If they have a normal healthy liver, the liver enzymes tend to rise, increase when you have severe vomiting. Similarly, bilirubin can increase, but not to a high extent. About 10% of patients with hyperemesis also show elevated amylase and lipase. Okay. So these are changes that usually occur with severe vomiting, nausea and vomiting. Like you have hyperkalemia, hyponatremia, it can also lead to conditions like hypomagnesemia and hypokalemia because of the severe vomiting. And more, in addition to vomiting, there is a somebody who has severe vomiting may not be taking adequate food, so that there is a dietary deprivation as well. Okay. And I told you earlier, when you look at the etiological factors also, the deranged thyroid functions also seems to be contributory. So mild case of hyperthyroidism can be resulting in severe vomiting. And the important thing is these people, when you are pregnant, you have a high HCG levels. The alpha subunit is shared between TSH and gonadotrophins, and that can also have an impact on increasing thyroid hormone levels. Okay, so all these changes basically happening because of the severe nausea, more than nausea, because of severe vomiting. Obviously, they will throw out whatever they eat. So there are certain risks to the mother because of this severe vomiting. And I told at the beginning, they can have dehydration and electrolyte imbalance, and even for your diagnosis, that is a requirement. Now, people have severe dehydration. There are 2 or 3 very serious, life-threatening problems they can end up having. One is called Wernicke's encephalopathy. Okay, Wernicke's encephalopathy occurs as a result of thiamine deficiency, and they present with neurological symptoms like blurred vision and confusion, memory problems, being drowsy, being unsteady. Okay, and when you examine, they have certain neurological signs like nystagmus and hyporeflexia because of these changes in the central nervous system. Okay. What you have to remember is not to ignore patients who have severe nausea and vomiting, because although patient might be sort of ambulatory and doing lots of things, this severe vomiting you have to manage, because otherwise you can end up having serious complications like this. Another serious complication that can arise is what's called Korsakoff psychosis. Again, where there is memory loss and impaired ability to learn and do things. Okay. So both these conditions, Wernicke's encephalopathy and Korsakoff psychosis, are occurring as a result of mainly vitamin deficiency and dehydration. Okay. Which sometimes, if you don't act fast, do what is necessary on time, can lead to long-term even damage to the baby. Generally, patients with severe nausea and vomiting in pregnancy, there is no major threat of fetal loss, there's no major threat of miscarriage, but there are some studies which shows that there is increased risk of poor weight gain, small baby, and preterm delivery. Okay, so those are the potential complications you can have with the fetus if you have severe nausea and vomiting during the pregnancy. Okay, sorry, I'm going back. Okay, now when you have these patients who now they will just come and present to you with severe nausea and vomiting, you have to, when you're dealing with the patient, it's very important. Now what you want to do is basically you have to establish a diagnosis. Now I said to establish a diagnosis, number one, you must show that there is dehydration, there is electrolyte imbalance, and also there is weight loss. So you could, once you establish diagnosis, now again I told you, you have to rule out, when you come to diagnosis, you have to rule out other possible causes of vomiting in pregnancy, which may be related to pregnancy and some may not be related to pregnancy. So when you take your history, you need to include questions to confirm your diagnosis and also to exclude other possibilities. So that you need to go into certain things like urinary tract symptoms, symptoms of urinary tract infection, any abdominal pain. Likewise, you might need to exclude other reasons. And also your examination should look at confirming a diagnosis, excluding other causes, and also assessing the potential complications. Okay, so you need to look at all these aspects, like looking at temperature, blood pressure, pulse, oxygen saturation, look at the respiration. Your abdominal examination becomes very important to make sure there is a pregnancy. Your ultrasound scans becomes important, right? So you need to tailor your investigations, history, examination and investigations to rule out other possibilities and of course confirm your diagnosis. Now this is what I told you earlier also, the scoring system. This is useful to assess the impact of severe vomiting on the patient so that you take appropriate early action, like if you have a severe dehydrated patient, not to wait too long to manage, because you know this can lead to serious neurological impairments. Okay, right. Now, once you want to done the assessment, done the history taking, done the excluded the other possibilities, and confirmed your diagnosis, and confirmed that she has an intrauterine pregnancy, which you can use an ultrasound scan for that purpose. You need to assess the patient with regard to all this. When you look at this, the patient will be, of course, especially when they have severe nausea, vomiting, they will have a very anxious appearance. They will have a weight loss. Because of dehydration, they have all these symptoms of sunken eyes, poor skin elasticity, dry trunk. There will be tachycardic, hypotensive, right? Having icterus and all that. Because this is an important assessment, it's important for you to take appropriate action and manage early. I told you, if you delay the diagnosis, delay the correction of hypovolemia, they are going to end up in those serious complications like what I told you, Korsakoff psychosis and Wernicke's encephalopathy, which can even sometimes kill the patient. Okay, right. So when you have done the basic history taking and examination, your investigations are trying to rule out other possibilities, and of course in this particular pregnancy, assessing the severity of the problem. So you need to do especially urine assessments to exclude urinary tract infection. Then you need to look at assessing the degree of dehydration, assessing the degree of electrolyte imbalance, excluding the possibility of infection, assessing the degree of hypoglycemia. Sometimes as vomiting can occur because of ketoacidosis, so in that case, hyperglycemia. So you need to try and do investigations to exclude other possibilities as well. Okay. So once you have done that, of course, the ultrasound scan is helpful to confirm the pregnancy, exclude the possibility of things like multiple pregnancy, and trophoblastic disease. Okay. So they need to do certain investigations to have a baseline. Okay. Now, these patients who have come to you and with severe vomiting, very often you may sort of consider this as a very common and simple symptom. But the important thing is to realize that if you don't attend on time and manage this severe hyperemesis gravidarum, you can have serious complications. So because of that, if you have severe vomiting and they can't keep any fluid in, or if there is evidence of weight loss and electrolyte imbalance, and if they are patients having this kind of thing with additional comorbidities, it's better to admit them. So if you have severe nausea and vomiting, you are not going to manage them as outpatients. You need to have a careful monitoring and assess the reasons for vomiting and make sure that they are managed appropriately to reduce the complications. Okay. Now, the objectives of your management is to, of course, confirm diagnosis, as I told you, confirm, determine the severity, correct all your electrolytes and fluid and electrolyte imbalance, okay? Improve their food intake by changing various dietary habits, and of course, you need to make sure there is no adverse effects on the fetus, and you also have to make sure there is no adverse serious complications on the mother. Okay, so there are the things that you are going to achieve by management. Okay, and determine the severity, give the fluids, correct the hypovolemia, and then look at preventing serious complications on this patient. Okay, because as far as you intervene early, your results are much better. Okay, now what you do? Okay, I said you need to admit these patients. I give you the criteria for admission. But when you have to manage these patients, one thing, of course, you have to manage, importantly, to reassure them, because they will also be worried, especially when they are pregnant and having this severe vomiting. They'll be worried about the pregnancy. They'll be worried about what's happened to the baby. So you need to reassure us. I told you have to be hospitalized if the symptoms are severe. You have to exclude other causes. You have to have some kind of a dietary modification, and of course, you have to rehydrate them. If you are dehydrated, you have to rehydrate, and of course, you have to now stop vomiting, because whatever you do, if he keeps on vomiting, also the complications will come. Okay. Now, with regard to dietary changes in these patients with hyperemesis, there are a few things you should pay attention to. One, of course, one of the options for these patients who have severe hyperemesis gravidarum is to make sure when they get up in the morning, not to start working with an empty stomach. Try to take something light at the beginning. Then there are certain things like patients herself might find the certain foods, certain drinks, certain liquids she will by sort of a trial and error, she'll find some of these things won't interfere with her vomiting, and in fact she will be better off. So you need to look at that, because that will be variable depending on the patient. So what you need to look at, how you can modify the dietary habits. Okay. I told you about taking small quantities frequently. I told you about early morning thing. Okay. Then you must avoid taking spicy food and other things which can also, because with this severe nausea and vomiting, one thing which can happen is you can even have things of Malrevite syndrome, like having traumatized of low esophageal varices, and then you can have Hyperemesis. Okay. As a result, you must try to avoid a lot of these fat-rich and spicy foods as well. So these are some dietary modifications you can make in these patients. Okay. So patients will feel, feel that there are what certain things are important in life to avoid this thing. You must make sure that these people who are going through pregnancy, having serious vomiting, do not end up having a lot of psychological and stressful situations as well. Because it's common to find that if the patients who are pregnant and having severe vomiting, in addition, they have a lot of additional stress factors that also can worsen their situation. So you need to look at adjusting their lifestyle, you must look at adjusting their diets. Then certain people also will find, when you look at the diet, foods with ginger, or you are having a drink with ginger, a ginger tea, right? Using that, either foods with ginger or with ginger tea, ginger itself seems to be having an anti-emetic effect. People who take these foods with ginger also seems to be having improvement in their symptoms. So that's again something you can consider when you looking at dietary habit changes. Okay, this is what I showed you, spoke to you. It's a non-pharmacological intervention. It has been shown scientifically also that it can have an impact on the vomiting by activity against similar to a drug on ondansetron. Okay, it's a similar kind of action. Now, when you look at rehydration of these patients who are having severe nausea and vomiting, you must make sure the fluids you use is saline with additional potassium chloride, because you can use both fluids and electrolytes. Okay? And you have to monitor the electrolyte changes, right? Certainly, in these patients with this vomiting, you should not be using dextrose infusions, because that can worsen their situations. And when you are giving fluid and electrolytes, look at providing certain B vitamins, as I told you, which are important to maintain their neurological status. Because I said earlier, lot of dehydration, having thiamine deficiency can precipitate this Wernicke's encephalopathy. Okay, so make sure you, while you are rehydrating, make sure you use the correct fluid, and you will be able to provide the necessary vitamins also through your intravenous lines. Okay, so look at all these: rehydration, correction of electrolyte imbalance, and providing some nutritional supplement. With all this rehydration, with your dietary modifications, you can use certain antiemetics, and these are the antiemetics that have been recommended. Okay, you can, here locally you have cyclizine and promethazine. You can use the cyclizine or chlorpromazine tablets, right? Then as a next line, you can use metoclopramide, Maxalon, or that kind of, and domperidone, and ondansetron can be used as a next line drug. Rarely, patients with intractable very severe nausea and vomiting during pregnancy, there seems to be adequate sort of evidence to suggest that steroids are helpful, either dexamethasone or maybe prednisolone or hydrocortisone could be used to control severe nausea and vomiting in patients who have these severe intractable symptoms. Okay, right. So if you are giving this, I said you have to correct electrolyte imbalance, you have to correct the hydration, you must look at what electrolytes are required, what nutritional components are required. If they require sort of various vitamins, then you should be able to give it intravenously even during this course of hospital admission with severe nausea and vomiting. And I don't have to say the people who have this, some people who are really ill and with severe, having severe nausea and vomiting, they will also have problems of psychological disturbances. So you need to try and give it a lot of psychological support. And in extremely rare situations, I'm talking about, maybe I have not done any of these, but it's in the literature. In extreme rare situations, you might even think of pregnancy termination in these patients who have intractable severe nausea and vomiting. Okay, so that's something that you may have to do. Right, within the next 10-15 minutes, we'll look at some other minor symptoms the patients are likely to have. Okay, look at some other minor symptoms that the patients are likely to have. Okay. You will find that a lot of people who are pregnant complaining of heartburns. It could be due to severe nausea and vomiting. I said in there's a lot of vomiting, you can have gastric kind of a Mayer-Weiss syndrome, and you can have gastric contents coming out and complaining of epigastric pain. Now, this happens very often with because progesterone is a vasodilator. It's a smooth muscle relaxation occurs with progesterone, and this can weaken the sphincter, gastroesophageal sphincter, and that might promote vomiting in these patients. So if you want to treat heartburns, of course, one thing, of course, don't lie down immediately after a meal. Avoid lot of, I told you to avoid lot of spicy food, right? Try and adjust your diet to take small frequent meals rather than having heavy meals. Okay, and in addition to that, of course, you can use antacids and gastric motility stimulants like metoclopramide and things to improve to improve their outcome. Okay. Then you have this condition called thalassemia. It's basically, sometimes you find these people who are pregnant keeps on vomiting, not vomiting, so they keep on spitting because they keep on having a lot of salivation. Okay, so again, there's no exact explanation why they get it, and this is called thalassemia. Okay, there's no specific drug that you can give them to reduce this increased salivation, but things like regular brushing, chewing like chewing gum and things might help, but There's no drug that you can say. Sometimes they go on, and very often these first trimester symptoms would get worse in the around 9-10 weeks, and they get better towards the latter part of first trimester and maybe second trimester. People who are pregnant very often complain of fatigueness, right? Which is sometimes due to, when you are pregnant, you are normal. There's a normal physiological drop in their blood pressure. There's even when you are fasting, even in a fasting state, glucose goes from mother to the fetus, and that's why your fasting blood sugar levels are lower in pregnancy than in non-pregnant people, right? Because of all these facts, anemia, all can contribute to this patient feeling a lot of tiredness as well. Patients who are pregnant complain of low backache, and that is one of the reasons for having low backache is, we know when you are pregnant, when your sort of tummy is getting bigger, your spine seems to bend backwards. Okay, you can see the way that they are walking. If you look at a pregnant woman walking, they walk with a sort of a exaggerated lumbar curve, curving backwards. So that can have a strain on the muscles and then cause backache. Okay, so if you are suffering from backache, obviously you need to make sure you sort of maintain your sort of center of gravity. You may have to adjust your position, but certainly don't do anything which can worsen your backache, like bending, like lifting heavy objects, right? Then it will be helpful if when you lie down, keep your back straight with after bending your knees. Right? If you want to pick up anything from the floor, sort of go down and pick up rather than sort of bending your back. So basically, from your other things also, you must have learned how to care for your back in cases of backache. So all those precautions you need to take. Sometimes they experience not only lower backache, upper backache, because of sometimes the changes in the breast, with enlarging breast, the weight can increase, and then it can have some impact on your upper backache as well. Okay, so patients who are pregnant will keep on complaining all these most of the time. So the husband will have to just keep on listening and make sure you tolerate them as far as possible. Okay. Then they tend to have this, because when you are pregnant, you tend to retain water and electrolytes. That's why you can see when you are pregnant, a lot of people have ankle swelling, right? Because in spite of having a normal blood pressure. So that is again because you have retaining fluid and electrolytes, which can occur also in the hand. In the hand, you have the median nerve going under the flexor reticulum, and when you have swelling, you can compress the median nerve, and then of course can have symptoms related to the median nerve supply, like in carpal tunnel syndrome. Okay, so usual management would be resting, sprinting, and maybe giving steroids also would be helpful. People who are pregnant tend to have increased vaginal discharge, which is again a normal phenomenon that you find. They often will come and complain to you, I'm having a lot of discharge, and that is a normal thing to happen because of the change in the vascularity of the pelvic organs, cervix, and the genital tract. And also there is high amount of conversion of because of high conversion of glycogen in the cells, there is high content of lactobacilli, which can all contribute to a high vaginal discharge. People who are pregnant tend to have high frequency of urination, And this is very common. The high increased frequency is common in the first trimester and the latter part of the trimester, because even in the first trimester you find the enlarging uterus remains within the uterine cavity, pelvic cavity, and pelvic cavity being very covered with bone and a fixed space. When you have a enlarging uterus, the space for the bladder to enlarge becomes less, right? So that they can have increased frequency as a result. And in the latter part of pregnancy, again, when the fetal head engages into the drops into the pelvis, again within that bony pelvis, the space for the bladder to distend is less, and they can have increased frequency. Okay. People who are pregnant complain of constipation. As I told you earlier, progesterone is a smooth muscle relaxant. So when you have a smooth muscle relaxation, you can end up in constipation. This is mainly during pregnancy, because of the high level of progesterone, your motility of the whole gastrointestinal tract becomes less. All the smooth muscles start relaxing from top to bottom. Okay. Then another two common findings in patients who are pregnant are the varicose veins and hemorrhoids. Okay. So again, what happens is in pregnancy, because of the high level of progesterone, the vascular smooth muscles also start relaxing. So if it can relax around smooth vessels around the anus, or it can relax vessels in anywhere else. Okay. Now, during pregnancy, it's also in addition to this normal vascular sort of smooth muscle relaxation because of high levels of estrogens, you can have mechanical issues like having an enlarged uterus pressing on the IVC, which can interfere with venous circulation, again, which can even contribute to the varicose veins and hemorrhoids. Okay. Then people who are pregnant also complain of leg cramps. It's a very common thing. There's no exact cause found for you to why people are having cramps. You must make sure you have adequate fluid intake. You must make sure you have adequate salts taken during sort of pregnancy. So there's various thoughts about whether it's calcium phosphorus imbalance or not enough calcium. But what you can do is, like it's shown here, you can do some exercises by dorsiflexing the foot. You see, when you do that movement, your calf muscles get sort of stretched, and because of that, you may not experience cramps. You can avoid getting cramps when you're pregnant. So that some exercises before you go to bed are helpful. Okay. Sorry, I'm going back. Okay, this is again something I said. People who are pregnant have to have increased edema because of vasodilatation and also because of pressure on the uterus. I spoke to you about the varicosities. As you said, we said you can have hemorrhoids, which is the varicosities around the anus, but also because of similar thing, you can find that people who are pregnant also have tendency to have increased varicose veins. Now, you don't do anything during pregnancy for varicose veins. You don't treat because once the pregnancy is over, it's very likely the things will get better. if at all, if it's painful and if the varicose giving trouble, you can use some pressure stockings or things like a tube grip, right, to support the vessels, which will be helpful to relieve the pain. So there's no definitive treatment that you will be undertaking during pregnancy for varicose veins also. Okay. People who are pregnant very often complain of insomnia. Okay. So that may be because of fetal movements, maybe enlarging uterus, maybe because of their discomfort. Okay. They also, you find the people who are pregnant, when you, in the early part of pregnancy, what happens is, you have the uterus and uterus will start enlarging. Once the uterus starts enlarging, you have the round ligaments on either side and they will start stretching. And sometimes they feel this as pain because of stretching of the round ligament, right? So on either side, you might have pain. So you can manage this with simple analgesics. People who are pregnant complain of hyperventilation and they are shortness of breath. That is maybe, actually you find when you people when they are pregnant, when you are going to the latter part of pregnancy, they because of the enlarging uterus, because of the elevation of diaphragm, they sort of try to hard to take a breath, right? So that is something that you feel. Finally, we always say, when you measure blood pressure in a pregnant woman, measure the blood pressure in the left lateral position or in the seated position. The reason is, you can now, when the uterus is enlarging, and usually you find the uterus also dextrorotates, and this enlarging uterus can compress the inferior vena cava, which is also on the right side. Okay. So if you have compression of the IVC, venous return from the legs will get less, and you can have a dropping of the blood pressure, which is called supine hypertension syndrome. Now, when you turn the patient, okay, when you turn the patient to the left, like what you see here, when you turn the patient to the left, if you are looking like from above here, when you turn the patient, the pressure on the intravenous vena cava will get less because the uterus will get sort of lifted up and fall onto the left side. Okay. So, that is why very often, not very often, if you are measuring blood pressure in a pregnant woman, it is mandatory that you measure it in the left lateral or in the seated position. Okay, right. So those are sort of minor symptoms that very often the pregnant people might complain, and of course there's no most of the time there's no definite explanation as to why they get some of these symptoms, but certainly most of these symptoms are restricted to the first trimester and early part of the second trimester. But of course, some of the symptoms might get worse in the latter part of pregnancy, like having breathlessness, trying to have difficulty in breathing. Okay. But the important thing is for you to be understanding that these symptoms are there, because these people need help. You have to realize people, when they are pregnant, they are a completely different set of people. They cannot maintain what they did when they are not pregnant. So that's very important for patients and also the sort of caregivers and the husbands to understand these changes so that you care them properly. Okay, thank you very much. I think it's time that we stop. I think you must be having another lecture. Right. Do you have another lecture now? Can somebody talk?
Yes, sir.
You have another lecture. Okay. Right. Who's doing it? Okay, doesn't matter. Okay, fine. Then you join the other one. Okay, I will stop here. Thanks.